followers and listeners to the latest installment of the Spiro Plastic Surgery podcast series. We're now on episode 7 of Surgeon by Trade, Artist at Heart. Today we decided to hit on a very important topic out there that a lot of you have asked about. We're going to talk about second chances, mastering implant, breast, cosmetic, and reconstructive surgery. You know me, Dr. Spiro, but here's our moderator. You've seen Gina on other podcasts before.
Hi,
Gina
guys.
is our stellar nurse, and she is a great moderator, and we're going to start right off. Welcome, Gina.
Thanks
Again
Yeah.
for grounding everything and being the moderator.
Yeah,
You're gonna
thanks
keep
for
me in
having me.
place.
Yep. All right, so we're going to start with something that I think people come very far to see you about. You do all the time and you do it great. So why do you feel like, breast implant revision surgery needs its own episode podcast on its own?
Well, I'll tell you, probably we need 3 or 4 episodes.
Yeah.
We're going to try to keep
Right.
people's attention, do it in one episode. There's a lot of breast implant surgery done out there, and unfortunately, the way the human body goes, there's a lot of issues related to it. So there's a lot of need for revision surgery. And as you know, we see a lot of patients who end up down the rabbit hole somewhere else where they've had one surgery, turns into 2, turns into 4, turns into 9. It's probably the following we get from people to fly in from all over the country, the most patients from the farthest afield. So I think it really needed to be talked about. There's a lot of little nuances and complexity.
I think that it's kind of also the most challenging. And it's different from primary surgery, primary other procedures. It's kind of got its own world.
Yeah.
So can you kind of explain what makes it different from just a first-time procedure, a first-time breast aug, in terms of, what
Sure,
you do?
let's start with that. Patients often perceive that an implant revision or any revision is a more simplified procedure, and and I'm not here to make anybody complicated, but I'm here to really, I have a good knack of being able to look at somebody, know the problem, figure it out, solve the problem.
Yeah.
And so it's not a redo of a simple thing. It's a completely new surgery. And again, in an effort not to make it complicated, I want to solve it in one operation. So some of the issues, capsule formation or lack thereof, prior surgeon decision-making may have led to an onslaught of additional issues. Oftentimes we hear, as you know, patients who've had more than one surgery, the problem gets worse
Right.
as the attempted solutions go on.
Yeah.
So, the most common reason patients have had 2, 3, 4, 9 other surgeries is there's not been a definitive solution. It's been Band-Aids applied, and I think that's why I think it's important for people to just understand that these are surgeries that are can be solved in one surgery, but are a lot more complicated than people or the original surgeon would like them to be.
Right.
So.
And I think the ones that we see the most, because, I'm in the room with you a lot of the time, implant malposition, capsular contracture, shape or size dissatisfaction, they all have their own category. So maybe we'll kind of go one by one, because I think some people have multiple, some people just deal with one. So
Exactly.
implant malposition, too high, too low, too lateral, symastia. So kind of how do you go about that? What do you see often?
So that's one of the most common things.
Yeah.
It's implant malposition, and it really boils down to you got to look at somebody's anatomy. It's kind of like you're the forensic surgeon before you're the actual surgeon.
Right.
You got to look at somebody and figure out why did they end up like this, first of all. So you kind of have to be a sleuth, and you see me in the room and I'm looking at somebody, and with 29 years of experience, I could kind of tell within seconds of looking at somebody.
Yeah.
And patients will often say, wow, nobody ever looked at me like that.
Yeah.
Nobody ever said that.
I didn't notice that.
I didn't notice that.
Yeah.
My other surgeon didn't say anything about
Yeah.
that. So why do they occur? Well, a lot of it's just due to chest wall asymmetry. Implants could be too low, they could be bottomed out, they could be too high, they could be laterally displaced, they could have symasty where the uniboob, as a lot of women refer to it.
Yeah.
So implant malposition could take many different forms. Solutions, pocket repair, internal bra, use of acellular dermal matrix, that's either human or non-human PIC tissue grafts, P4HB, Galaflex, it's known by. All these are in our tools in the toolbox to solve it.
Yeah. And capsular contracture. So kind of something many patients hear about, don't fully understand. So what is that? Explain that for people that might not know.
So the opposite end of implants which have stretched out by gravity. Gravity is the number one nemesis.
Always wins.
Always wins. Yeah. And if you've got a torso shape that's not favorable for implants, gravity is going to either take the implants, push them out laterally, or bottom them out. And the solutions for those implant malpositions are sort of disassembling, taking all the scar tissue out, which usually the previous surgeon doesn't do in the redo, and you got to build a whole new space. Well, in capsular contracture, it's kind of the opposite. Things have clamped down, the human body created too much scar around it, and limited surgery for capsular contracture ends up with limited outcomes.
Right.
So just like the woman with implant malposition is back for 2, 3, 4, 5 surgeries, the woman with capsular contracture could be the same. So the solutions mean you have to take all the scar tissue out and then reassemble and recreate a new implant space, which may mean a pocket change. It may mean using those same materials, tissue grafts, meshes, internal bras, but capsulectomy is the key. And the commonality being usually in redos done elsewhere before they come here, not enough was done. They either underestimated the magnitude of the issue or they undertreated it. And, so for capsular contracture, you got to get rid of all the capsule, not part of it.
Right.
You got to get rid of all of it. But if you get rid of all of it, you're opening up Pandora's box for other issues.
Right.
So you've got to go into this saying, I'm going to identify all the problems and I'm going to have solutions to fix all these issues. So what it's maybe brings us back to the same thing, using tissue grafts, using internal bras. Again, it's not doing too much.
Right.
Or making something more complicated than it is. It's trying to save somebody from ending up with one surgery leading to 2, leading to 4, leading to 9.
And sometimes, I've seen people that you fixed 6, 7 surgeries in one.
Yeah.
And, they think that, they just went in and did a little tweak here and there, and it's because they're putting Band-Aids on, and you're kind of going deeper and fixing everything that needs to be fixed.
Right.
Yeah.
Exactly.
I think another thing that people come and talk about a lot and have issues with is shape or size dissatisfaction. I think there's a lot that goes into that, and I know you don't go just by CC, which a lot of people do, and they come in and say, I want this, and you kind of explain to them what and why behind it. So can you kind of give briefly what that looks like when people talk about size?
Well, first I like to sit with somebody and I say, well, what were you after when you had your first surgery? I didn't know you then, but I kind of look and I see what you may have looked like. It helps when people bring pictures of themselves before, or they are frank and say, okay, I kind of was looking for this, but I ended up with this. So wrong implant choice is a big issue initially. Maybe they were too big, maybe they were too small, maybe they wanted cleavage and their breasts are too far apart. So again, it's back to that sort of forensic identifying what led to the problem. And I kind of give the previous surgeon the benefit of the doubt and I say, let me assume that first surgeon was a good surgeon. And things went awry, and why did they go awry? So, I look for all that. I look for torso asymmetry, implant types that may have been mismatched to the body. hyperanimation problems where they're complaining too much muscle activity. So sometimes I'll take implants under muscle and put them over muscle. Sometimes I'll take implants over muscle and put them under muscle.
Yeah. So let's do two more that I see a lot, you see a lot. They could kind of have their episode of their own.
Yeah.
Revision after a breast lift. So kind of what kind of issues tend to appear after a breast lift that require corrective work? What do you usually see?
Well, you remember this, like we recently had a patient in the office like that, where we're often, after I evaluate and I see, they say, I was told this couldn't be fixed, or this was too risky to fix.
Right.
Usually that's not, you can solve everything. You just have to have a patient willing to do it,
Right.
and a surgeon who's got the breadth of understanding
Right.
to do it. So I always tell patients, none of this is really complicated. It's just you got to solve the issue. So asymmetries, often nipple and areola malposition. The nipples are too high, they're too far apart, they're uneven, they're too low. I mean, these are solvable issues. What helps is when patients bring previous operative reports in,
Right.
they know something about their previous surgery, they know what implant they had in. It helps me. Maybe they're complaining they had upper fullness and now they don't. So I'm able to help solve that. But I think gaining insight
Yeah.
into what somebody really wants. I don't come into a room and dictate what should be done. I tell them how something gets done, but I don't tell them what size they should be.
Right.
But if they say they want this and they want this and they want this, I'm going to tell them, okay, this is how we
Realistic
achieve that.
outcomes,
Yeah.
right?
So correction could be with reshaping, maybe fat grafting, implant, different implants, implant addition in people who just had a failed breast lift. My big thing, we get people coming from all over the country, the concept of dermoglandular flap autoaugmentation, which means taking their own breast tissue and figuring out a way to actually make that additive into a better shape.
Yeah.
So
Lastly, reconstruction revisions. How does that kind of, for patients who've had it, especially after radiation, what complications or challenges do you see often, and how do you fix that?
So reconstructive implant revision surgery kind of is in the same group as cosmetic revision implant surgery, but there are some other challenges.
Yeah.
And as you know, the number one challenge we face are women who had maybe cancer-related breast surgery, breast implant reconstruction, and then they had to have radiation. And in every patient, radiation affects them some degree.
Right.
So radiation effects and limitations will dictate what I may be able to offer them. So in patients who've been radiated, there may be limitations or they may require bigger surgeries. Sometimes that require what we refer to as autologous tissue, meaning taking parts of their own body, flaps as we call them, whether that's from the back or from other areas, may require fat grafting, staging the procedures, fixing contour irregularities from absence of tissue. So one of the big reconstructive revision things that I'm known for now is disassembling, and again, this goes back to the cosmetic revision,
Right.
where you've got to look at somebody and say, I'm not going to come up with the simplest way to do it.
Yeah.
I'm going to come up with the definitive way to do
Yes.
it.
Right.
The way that's going to solve the problem with one surgery. So one of the things I do is the total alloderm wrap, the human tissue wrap, the 360 living tissue wrap that I create. And, we're doing the podcast today about this. We saw one of those
Yeah.
women was in today
Yeah.
to get skincare, Botox.
Yeah.
She became a patient for life.
Yeah.
She caught me in the hall, said, I'm so glad I saw you today. I
Yeah.
just want to tell you I'm a different person
Yeah.
now. She was trapped in that radiated body with a terrible result, which
Yeah.
ruined, it affected every aspect of her life negatively.
Right.
And now she's literally a different person.
Yeah.
So doing this, understanding you got to really do a full-on operation to solve these problems that other surgeons are not offering because they may not know how to do it. They don't want to go all in on this. It's too much surgery for them. And for us, it's kind of like part of what we do.
Day to day.
Yeah.
Yeah. So I know about this kind of more than anyone because I'm in the room with you, but you go into so much detail, give each patient so much time. And I think that that's super important. So kind of how do you evaluate a revision candidate? Where do you start? I know we go through as nurses a surgical history. We review it with you before you even go in the room. You look at it the night before. It's so important to us. So what matters the most to you? Where do you start? How do you kind of go about all that?
Yeah, that's a good one. So, I'm an it's the tagline, surgeon by trade and artist at heart. And there's a reason for that tagline. I'm an artist. I look at things differently than other people.
Yeah.
When I walk into a room and I look at somebody already, my brain is moving at light speed, looking at artistry. You guys can see here that one of my paintings, which is that pop art, good humor thing, is in here. I painted that. So I look at everybody, everybody's an art project.
Yeah.
Everybody's an art project, but I'm a surgeon. So I'm looking at all that. And I want to get that interplay between art and surgery, art and surgery.
Right.
How am I going to create that sort of ideal, beautiful, normal out of a patient? But I'm looking at, are their goals realistic? Is it their time yet for
Right.
surgery? So that's how I'm evaluating somebody. The wheels are churning instantly as I walk into the room and start talking and seeing them.
So, in terms of kind of situations, some people you advise waiting, some people you advise not operating at all. How do you kind of go about that, when they come in?
So that's good too, because that's not artistry.
Right.
That's experience.
Right.
And that's being very cold and calculated. And somebody wants surgery, their tears are in their eyes, they've had a bunch of surgery. And I may look at somebody and I say, boy, you haven't recovered from the previous surgery and it's not your time yet. I gotta let tissue settle. I'm not kicking the can down the road on anybody, but I want to optimize their ability to get a definitive one surgical solution.
Right.
And sometimes, as you know, people will come here having had surgery within like 2-3 months and they're not ready.
Yeah.
And then I say, you got to come back and see me. We're not giving up on you by telling you it's not your time,
Right.
but there will be a time. I just want to make it the right time.
Yeah.
So,
Yeah. All right. So, something that when people come in and talk about previous surgeons, sometimes you don't even want to hear it. You'll look at the op report and you'll figure it out on your own, but kind of what's a red flag for someone choosing a surgeon, especially a revision surgeon, when they've had X amount of surgeries and it's like, how do you know?
So the only advice I can give people is anybody who's over-promising in this, never use the word perfect. If somebody says, oh, you're going to be perfect, there's nothing perfect.
Yeah.
Nothing in the world's perfect. So they go to a surgeon who has no ability to give a detailed explanation and looks at them for 5 seconds and say, okay, well, you could sign up for surgery. That doesn't, that's not very good. So I wouldn't do that. If I was a patient, I would sort of do an about face and leave. Limited before and afters, that would be suspect. You got to connect. You want a good communicator.
Yeah.
Somebody who can come up with a plan right away.
Yeah.
Give the person hope, and then deliver on the hope.
Right. Exactly.
So, yeah.
Yeah. All right, case examples. This one I kind of like. So one of our patients recently who had under the muscle implant with capsular contracture. So kind of walk us through an example of that complex case and how you figure that.
So that patient who you're referring to had under the muscle surgery.
Yeah.
And with severe capsular contracture, I had to do a total capsulectomy, take all scar tissue out, use non-human pig tissue graft, creating an internal bra, broke the chain of repeat capsular contracture.
Right.
So that's the key for that. You got to because once you get capsular contracture, if you don't do big surgery, you're going to end up with it again. So that was that.
Yeah.
So now let's talk about bottoming out problems.
Yeah.
So bottoming out is sort of like a colloquial expression. Patients come in and say, "Oh, my surgeon told me I bottomed out."
Yeah.
It's gravity, just dropped everything out. For some patients, it flips the nipple up. There's no upper pole volume. It's because they didn't get enough capsule formation or their body just wasn't favorable for implant.
Right.
So that's where that internal bra support. So that may again require near total capsulectomy. The scar layer's got to come out so that you can reshape the breast
Right.
entirely. And yeah, and all these patients I do some sort of internal bra support with.
Yeah. Radiated patient. So we just had a radiated patient that kind of came from across the country, and staging. I think that's something that we're you always do stage procedures most of the time with something like this. So how do you explain the stages? Why is it important?
So radiated tissue is not very reliable.
Yeah.
Doesn't heal well.
Yeah.
So sometimes you do have to stage things. Patients who fly across the country don't really want to hear that.
Right.
Again, I would like to say I'm more equipped or as equipped than anybody in the country to deliver in one operation a definitive final outcome. But also my experience tells me sometimes you gotta do it staged.
Yeah. All right. So main takeaways. Let's kind of go over some closing remarks.
Closing remarks.
Yeah. So if you can leave our patients and our viewers with one key message about revision surgery, what would it be?
So I was trained by a plastic surgeon, Dr. Ralph Millard, decades ago, who ended up being known as the world's greatest plastic surgeon of the 20th century. And he had principles. And in that, it was learn how to evaluate somebody, but know the ideal, beautiful, normal. And I put that into every patient.
I like that.
That's the main takeaway. If you're equipped as a surgeon and you're willing to go for broke, that was another of Millard's main principles, you can put it all together. And really, that's the simplest way to say it. We can go into a whole nother podcast about these takeaways, but that's the take-home message. That's really it. Understand the issue, gain insight into what they want.
Yeah.
Be an artist at heart, even if you're really not as good an artist as me, but plan it out so you can fix somebody in one surgery.
Yeah.
That's it.
This was great.
Gina, thanks for being
Thanks for having
moderating
me.
another great podcast.
Thank you.
I hope you've all learned a lot. Our podcast series grows. We're going to hit on other topics. Please stay tuned for episode 8. Remember, follow us on Instagram. Watch our TikTok videos. In fact, watch a lot of TikTok videos made by some of our patients
Yes.
about their experience with us. So thank you from Spiro Plastic Surgery, Gina and Dr. Spiro. Remember, surgeon by trade, artist at heart.